everyone, this is Fast Track for Anesthesia and ICU. Today I am going to talk about the management of acute heart failure in peripartum cardiomyopathy. The management is multidisciplinary approach including the obstetrician, cardiologist, anesthetist, neonatologist, critical care specialist. We have to maintain the adequate oxygenation, fluid and salt restriction, ventricular offloading by vasodilators and diuretics. What are the drugs we can use? Angiotensin converting enzyme inhibitor cannot be used as during the pregnancy due to birth defects. In second and third trimester, there is increased fetal loss, fetal renal dysfunction, oligohydroamniotic and congenital anomalies. But we can use it in postpartum, shown to improve the mortality. And if the patient is intolerant to the angiotensin converting enzyme inhibitor, we can give angiotensin receptor blocker. Angiotensin converting enzyme and angiotensin receptor blockers are not recommended to use in breastfeeding mothers because of risk of neonatal hypotension. Hydrolyzing nitrates can be used to reduce the afterload, preload, intracardiac filling pressures. Beta blockers can be used to improve the survival and also protective against the tachyarrhythmias. Digoxin, it's safe in pregnancy. Its positive inotropic effects and can be used in treatment in atrial fibrillation. There's narrow therapeutic index. Therefore, we have to monitor the digoxin plasma levels. Calcium channel blockers should be avoided due to negative inotropic effects. Aldosterone antagonists such as spironolactone is not recommended. Endomyocardial biopsy can be taken to assess whether the patient is responding to the immunoglobulins. If biopsy shows inflammation, we can give bromocriptine pentoxifilling. Prophylactic low molecular weight heparin is indicated because of high risk of venous thromboembolism and neurothrombosis. If the patient is deteriorated, ventilator support, inotropic support should be given. In severe cases, intra-aortic balloon pump, left ventricular assist device, extracorporeal membrane oxygenation should be considered. If not responding to the pharmacological therapy, heart transplantation, implantable defibrillators, cardiac resynchronization should be used. We can prevent aorta cable compression by avoiding the supine position, regular monitoring with ECG, oxygen saturation, blood pressure, and there should be low thresholds for invasive arterial blood pressure monitoring. Delivery should be planned according to the hemodynamic status. In uncomplicated status, we can use vaginal delivery, but with caution. In uncompensated patients, lower segment cesarean section should be performed. Titrated neuraxial anesthesia by incremental top-up of epidural or combined epidural and low-dose spinal anesthesia can be used. Neuraxial anesthesia reduces afterload, promoting forward flow, and avoid use of general anesthesia that reduces the myocardial contractility. If we use general anesthesia, smooth induction should be maintained, minimizing both hypotension and hypertension. Intubation response should be obtained by using high doses of rapid-acting opioids like fentanyl, remifentanil. Inotropes should be considered, dobutamine, calcium sensitizers. Vasopressors may be useful to counteract the vasodilatation, and that will maintain the coronary perfusion. Minimally invasive or invasive cardiac output monitoring can be done. Uretronic drugs should be used cautiously. Oxytocin will reduce the systemic vascular resistance markedly. Ergometrin will increase the afterload. Following the delivery, patient should be recovered in ICU with ongoing invasive hemodynamic monitoring, careful fluid management, adequate analgesia. If neuraxial block is used, timing of anticoagulation should be planned. Thanks for watching.